call Kat.
Yep. Okay, you're recording right now, so if you want to go ahead and do it. I'm going to call Kat, and then you can probably cut that off.
No, just record it. We can stream this.
Is she?
Are you started? Can I start talking?
Yeah, this is a recording, so it doesn't matter. We can edit it. So.
All right, everybody, welcome. Today is a perfect day, except for we have problems with YouTube. But it's a perfect day to do a live case and describe what's going to happen. It's a really cool case. I mean, there's nothing good on TV right now. The NBA Finals were last night. And when I say NBA Finals, I mean The Bachelorette was on last night. So today's all going to be endo, and we're going to talk about troubleshooting. Troubleshooting some things that can be frustrating as endodontists. So, you know what? Let's start this case, and I'm going to tell you a little bit about it. It's tooth number 21. Here we go. So it's tooth number 21, and it's one of those fast break situations where you kind of go halfway down the root, and if you look on that x-ray, it bifurcates, which is cool. It's cool anatomy, but it can be really, really frustrating when you can't get into like the lingual canal or whatever's going on. It's down deep. And so I'm going to show you how I problem solve it, and I'm going to show you how the GentleWave actually made that easier, how I employed that technology for it. If you look at the intraoral feed right now, what I'm doing is there was a failed restoration, and we're just taking it out. I am doing it without the rubber dam on, frankly, because I don't want to tear my rubber dam when I'm starting. So the patient's been anesthetized, and it is a vital case, symptomatic. And you saw that I removed the decay, removed the filling, and then single rubber dam placement with wing clamps. I do that a lot. There's tons of ways to do rubber dam isolation, but for me, that's the way that I like. So I'm isolating that, and gonna tuck that little piece of rubber dam that kind of folds at that cable surface, at that margin right there. So I'm just gonna kind of tuck it in. You can see that this is a carious exposure. You can see that it's full of decay, and there you go. We're going to just remove the decay. Lots of burrs to choose from. Everybody's got a preference. That cat can be skinned many different ways. For me, this is just a large round burr. It's on an extended shake. It's actually a Muntz burr. And I'm just going to remove the decay. And one of the things that we all deal with, and restorative guys are going to be more clued into this, but when you remove that decay, you can see how that enamel on that buccal is really translucent. And, you know, the idea is do you leave enamel, the enamel shell, where it's been undermined from the dentin? And for me, that's not something that I'm going to do. That's just going to flake off the foundation. And so I'm going to remove some of that undercut dentin and just kind of bring it back into where there's a dentinal substructure. Because you send a patient home with that on, they take one bite, and then part of that enamel fractures off, and then they're freaking out that something happened. So that's what I do. So I just try to take it away right now. You can see the exposure, the little pulpitis there. There is a stone in the way, so I'm going to pick at that a bit. And I use a rotary explorer, which is also called an SX Universal. And I'm going to pick that pulp out, pick that stone out, and instantly my mind, I'm leaning that file, trying to go down the buccal and the lingual wall, trying to see if I can feel that bifurcation in there. And that's something that, you know, I may find, I may not. I know it's halfway down that route, but I'm just hoping that I can get in it right off the bat. And then I'm switching to a 1506. Now, when you use a double bowed clamp like that, I find myself using 25 millimeter rotary files just so my handpiece isn't pushing on that bow. And I'm gonna, since I can feel that bow rocking a little bit, I'm going to put some caulking around it because I don't want any sort of fluid to come through or bleeding or whatnot. So I'm gonna now add some hypochlorite in my discovery phase. So I'm just gonna instrument in kind of a solution of sodium hypochlorite. And again, I'm using that tip trying to find where that bifurcation is. I'm feeling something down there. but I don't quite know what it is. It feels like there's a stone or there's something down there. So we'll, to be continued on that, investigate it. So I'm flushing basically so I can visualize where the fork is as much as I can. And then continue picking. And so when I look at my cone beam, you know, trying to get a little closer understanding of where that is. I'm feeling something with that 1506 rotary file. I can see how it's a fast break and it truly comes in at a steep angle, especially on that lingual side. So there's something there. You can see that little stone in there, see? And now I'm going to pick it out. So I'm going down to a smaller burr. You know, another option, and admittedly, you use what you like. You could use an ultrasonic, and in some ways it might let you see around it a little bit better, and it might actually flick up the stone. But sometimes I use whatever my assistant hands me, and this was really small. It's the purple of the Munspur, and trying to clean that up a little bit. Creates a lot of debris when you do it this way. So we're going to try to flush that debris up and go ahead and take a look at it and see if I can now get into that little lip that's blocking me out. And sometimes this can be really frustrating. Fortunately, I have a fantastic patient right now. They're not budging. Now, if you look on the screen, the little red box down there that's counting away is actual working time. So 7 minutes. Now, I guess this actual working time is not anesthetic in working time because I started this when I sat down. So I'm going back to that 1506 and I put a little bend in it, just like how we pre-bend hand files, and you can certainly hand file it too. And I'm just trying to see if I can get it to bite, because if I can get it to bite with this, I can feather it up, like paintbrush stroke it up and get it to open up and then make my life easy. And right now I'm not so successful at it. It's a bit of a struggle. Life is real, you know. So I'm going to be picking around for a bit. And it does feel like it's starting to catch, just starting to flicker right there. Let this puppy progress. Okay, now you can kind of see it. You see the little black spot right there? That's the lingual canal. So it's really a buccal-lingual bifurcation. Sometimes I've seen them where they're mesial-distal or off-axis a little bit. I'm fortunate when there's buccal-lingual, it's a little bit easier because I have more references from my cusps when I pre-bend a file and I try to go in there. And so it's taking a bite right there. Now I switched it to a 1504, and it's kind of a crown down technique. I'm trying to be conservative. I'm trying to use smaller files, but I can feel that file working and bending in there. And it is making me nervous. You can almost sense it with the tug back as I pull it out, as I'm trying to paint stroke it up. Like, I do not want to lose a tip on this thing. And so, you know, another option would be to go back with hand filing, but again, time is also of the essence in a busy practice, which my practice is fairly busy. I have a lot of, we have 3 doctors in our practice, and we're running multiple rooms. But an idea pops into my head. What if I just stop? I don't want to bend and break a file. What if I employ the GentleWave at this point? And will that allow me to get in there? And honestly, I've been doing the GentleWave since 2017. I've got a number of cases under my belt, and I've done this on molar cases. And this, like, well, you know what? Might as well try it on a bicuspid case. So you saw me fit the matrix in there, just seated it on. I wanted to make sure my opening and the pin placement of the matrix can actually be seated in there. And then I take a cotton ball that's saturated in isopropyl alcohol, and I'm just putting it in and around the tooth and blowing it dry. And now I've kind of modified the sound seal, and I've modified it because I got my own little tip here that's been pre-bent. And you know, this tip is actually a tip that's used like with astringent around the gum tissue, like if you have bleeding gums. And I've just taken the tuft out of it, and now I'm using that with my sound seal, because that sickle shape allows me to kind of paint it in as you're seeing, and paint it around the interproximals, just so I know that when I set that matrix on it, it's going to work. And you know what? And after doing the number of these, I don't know how many hundreds of these I've done, this is an easier way of doing it. It's taken me a while. So it's a little endo hack trick for you, a GentleWave hack. And then I'm taking an Explorer and I'm actually just kind of painting it and making sure there's no voids or bubbles. And you know, you kind of want it like that partial set. Sometimes don't rush through this. If you let just the natural ambient light, maybe your microscope light's a little too powerful, but if you just let it kind of get semi-set, like if it's in that semi-state, not a full cure state, it's actually easier to draw it and not gouge it when you touch it with an Explorer if you get a little jiggles, if you had too much coffee, too much caffeine in your hands or something. So you can have a steady hand and it not dish out that wall. And so I painted it in. And then I replaced the matrix. And now this is another endo hack, another little trick for you. What I'm doing with the sound seal is I've turned it up and I'm actually injecting it up underneath, that was kind of loud, up underneath the platform. And if you watch it, the platform actually, matrix actually carries the sound seal and smooths it out quite nicely. And then I can go ahead and fill in all the negative space to become full with the sound seal and then cure it while I'm holding that. And so, you know, serves you to be ambidextrous or just have a really good assistant, and sometimes they can even hold that platform and then you can have your both hands if you need to use a mirror. But when you do it this way, you can get it all done in one setting. And then if you see how I'm curing it, I'm really curing it on the buccal or the lingual wall first and then the buccal wall, and there's strategy behind that. Because if I cure from the top down, like if I rest it right on that matrix, I got a tall depth to cure. But if I come in perpendicular, I'm only a few millimeters deep right there. So I can get a really good set in that fashion. And then you can't cure it too much, so once you pop the matrix off, you can just take it out, recure it, make sure it's set. And then I'm a big believer in refining my access. Sometimes on the APMs, these anterior premolar procedural instruments, a lot of guys don't do that. I'm gonna do it that way because A, I wanna see down that canal and I wanna see where that fork is and I wanna make sure I can get it because my job is now employing the sound wave, the GentleWave, I mean, because I can't really get to length in that. I'm picking it, but it's been in my file to the point of where I'm shuddering. I don't want to leave a soldier behind. I don't want to leave a tip in that. So I stopped and went to the fluid dynamics and see, hey, if I use these fluid dynamics, is that going to help me get to the end of this thing? Because I'm not painting, I haven't even determined my length yet. The other thing is with this APM, I always call that the dancing bubble. And it's just a little white cloud. And that's actually the fluid dynamics, that's where the shear force of the fluid dynamics is taking place. And the principles, as you can see in the explainer video, although that's for the molar, it's the same physics. Nothing's really different, it's just engineered differently in the procedural instrument. And so there's a lot of plus and minuses between these two things. And one of the things that I've learned in using these just over a ton of cases is that sort of dancing bubble. If you can imagine in your mind's eye, if you can keep it right parallel with the orifice, like it's right above it, it's just in line with it, it just seems to work really well. If I'm off axis, the dancing bubble will stream and bounce a little bit, and then, at least in my mind, I'm trying to maximize the fluid dynamics to work to my advantage, especially when I'm dealing with a fork in the road. So there's not a sound bar. The sound bar is really that head. Now you can see it in the window, and then just to the left of the window, I wonder, just to the left of the window right here is the vent. So one thing you want to do is look at that vent and never have it blocked. That wouldn't be good to block it. And you can see that bubble dancing, and as I'm moving around, I'm just trying to find the sweet spot and making sure that vent is patent, meaning sometimes some guys will actually use their other hand to hold. And actually, I'm going to do that here in a second. But if you do use your other hand to hold the procedural instrument on the tooth, you don't want to cover that vent, just FYI. Now, like I said, the fluid dynamics are going to be composed of several parts. You got the sound flow coming through with these optimized fluids that come through the console, through the procedural instrument. And where the shear force of the fluid dynamics meets each other, instead of it being in the chamber, like it is with the molar procedural instrument, it's in the head of the handpiece. And so that sound bar is, think of it as inside. And that shear force is what we're seeing between the two fluids in a degassed environment creating the cavitation cloud is right there. Now, if you look at it, you'll see my thumb now holding because it's more convenient. And I'm actually just using my tip of my fingernail. It's not like I'm putting a lot of force on it. But it also lets me see the window and then make sure that vent is open. So fluid dynamics takes place, creates the vortex in the handpiece, the procedural instrument, and that's where the negative pressure is, the engine is, which is why my mind wants to keep it right up above that orifice. And then the chemistry is going on in there because it is hypochlorite, after all, running through this. And it's kind of like running the extended cycle on the molar as far as the times go. And it's the 3%, it's the same protocol, it's same time, same agents with the sodium hypochlorite, the water, and the EDTA, the same concentration. So 3% is coming in here, sitting over it, and then it's allowing that vortex eddy to come down, and then the echo of the multisonic or the broad spectrum sound. That's how they describe it to us, and it just goes down through the fluids, and the hope is it's going to be lapping up against those two orifices and allowing me to make space and to get a better flow with my file, because like I said, I was in danger zone here. And so I decided along the way, sometimes you can stop, a few minutes into the cycle and then try to navigate and get your length. But I was so worried about this fork being so steep, such a steep angle as it comes in, that I chose to run the whole procedural instrument cycle on it. So it's going to get the full force of the wave on this one. I wasn't going to mess around. And as I was in my passive step back zone, or my passive length termination from my measurement on my cone beam, I always measure twice and try to cut once. But I was in my maybe 3/4 of the way down, maybe a little bit further. I was probably about 3 to 4, maybe 5 millimeters away from the apex. And the reason is the maybes is the buckle. I felt like I could get down it, but the lingual, it was catching up, and I couldn't tell. It kind of felt like perhaps they were coming together. You kind of get that feedback in those files as far as the directions that it's going, but I wasn't quite certain as to what it was doing. So hence the reason I think it's just completing like a circle for going around in there, inside the root as far as the anatomy. So for me, I'm using that almost done here. And then I'm going to have to check my lengths, figure out where we are, and see if that's going to work. By the way, I did watch the game last night. For all the Canadians out there, I'm sorry about the loss, but you should be proud. And Golden State, you are the Warriors. You a one point do or die scenario. Poor KD. Enough of basketball. Almost done. I don't watch The Bachelorette, but I had competition in the other room. My daughter watching The Bachelorette. We were fighting over the TV. So that's why I said it's a great day to make a movie, a GentleWave movie. So that dancing bubble, it's staying pretty consistent, and so that's good. I mean, I know those fluid dynamics, they're working as they should. Looks like we're coming to a close here. And if you notice, when I built that platform, I build it wide. I build it with a lot of girth to it, simply because you're rocking and the movement that you see here. Just don't want it to dislodge off that. I mean, it's missing half the crown from all that decay and everything I took out of it. When I do root canals, I'm really trying to keep a protocol in my mind, and I work in like a philosophy of eights, and I know that makes no sense right now, but I kind of divide this up into 4 steps in my mind, with access and the GentleWave, like maybe the pre-work with decay removal, and then into access and the GentleWave, then into the restorative phase. And I like to do them in 8-minute increments. Those are my goals. And I don't want to rush through it, but I want to know how to always maintain my schedule and be really conscious of what's going on in my office. And that's one thing that allowed me to kind of make the decision of going into the GentleWave, because I could spend 15, 20 minutes at times, maybe even longer, trying to negotiate down there in a high-risk scenario, in a scenario where I could potentially break the file. As I keep getting heavy-handed, the longer it goes, it seems like we just work and work and work, picking around, and I didn't want to do that. And now that I've gotten so comfortable and I've had so many cases with the GentleWave, this actually speeds up and keeps me on point. And so, hence the reason for using the GentleWave. And if you look, we're 22 minutes now into this case. You know, you can, when you watch the windows, I'll really pay attention to what comes out. I actually find that quite fascinating as to what comes out. And I'm always looking for puffs of maybe blood or pus or whatever the scenario may be. And this is no different. So I hold the handpiece is what I'm trying to say. And I pay attention to that. I make sure that bubble's dancing the whole time. You saw me remove the sound seal, and now I'm looking in there and noticing some bleeding coming out of that, which is good. And the theory is the fluid dynamics now took me to the end. Again, like I said, I was well shy. And so the thought came to me is, what if I just put some cones in here and take a working length to actually document where it's at, with me instrumenting really short and where I'm at now. So I'm just gonna try to dry this up so I can see the entrances to the two canals. And then my assistant Lindsay's passing me some cones. And I always try to put it in the more difficult one first, which in this case is the lingual. So I'm placing that cone in there and just letting it go till it binds, and then that's it. I'm just seeing where it's at. And we're going to take an x-ray. So you can see I'm well past the fork and it's short. So I got some more work to do, and that's fine. That was anticipated. Now the idea is how hard, how easy can I actually make up the difference and go to my kind of corrected working length. And so that's what I'm doing here. And what those lengths are was 21 on the buckle and 20 on the lingual. And I always use the reference points of the occlusal surface, just the cable surface margin of the access. And I use the calibrated marks. So when I'm looking at it, I'm actually looking at the marks on my file, and I'm taking them down to those marks as a reference point, as opposed to measuring on a finger ruler or just a hand ruler. And if you can remember, go back and watch it before, I'm getting to length now. And I'm not feeling that tight bend. It's fairly open. And that's great. I mean, that kind of confirms that, and the bleeding confirms that fluid got there, even though my materials can't, whether that be my file or even the gutta percha cone. And it would be really hard for me to try to place a 15 cone in there and just pre-bend it and get it to slide right in, because it was sort of an amorphous shape beyond that point. At least that's what it felt like. And so I'm trying to get some convenience for him here, and I went back with hypochlorite, and clearly we're making smear again, sterile smear. And you can see just that. So I've got that scenario where, if you saw in that working length, found the fork, came back into a common exit, which I didn't know was going to happen, back together. So it was like a 1 to 2 to 1 type scenario. As there was a connection down there, and just right there in the apical terminus. And then I'm going to flush again with some EDTA. These are pretty small now. You know, I'm still in the 20 size. I'm using a 20 rotary. And now I'm just going to paper point dry. 29 minutes into the case. Okay, so lingual again first because it's the most difficult to see, and I want to make sure I don't bend my cones and I can get them into place. So I put it in the lingual and then I'm activating it, kind of like a modified continuous wave, and just pushing on it, and clearly that heated element is binding really high. I am using BC sealer in this, and now I'm going to do the buckle. There we go, same technique. So I inject, and I'm going to place the buckle. And if you notice, it's the same order I did on the working length x-ray, or the cone fit x-ray, because who knows how the cones are going to crinkle and bend in that lower connection. And so I try to do everything exactly the same. And that's what I'm doing right here. So now just low down pack. And that's clean. I mean, that is even that kind of isthmus connection is pretty clean. And backfill at this point, you can see some of the sealer coming up. There we go, and a little bit of down pack. Now, I am going to restore this. I'm fortunate in my practice to have a combination of both guys who want temporizations and guys who want restorations, and maybe some of y'all feel different about that. I like restoring. I feel like it's a good service, but I also will always honor whatever the request is from the patient and their dentist, and we are a referral-based practice, so I do subscribe to do what I'm told. So went back to alcohol right after I was done with the obturation technique, and just kind of drying it up, blow it dry, and then I use a conditioning agent and then the bonding agent. It's a two-step, and like cure the bond. And I do that for lots of reasons, because you know, I want to make sure there isn't any schmutz inside that tooth, and that I'm really adapting the bond layer to the dentin and parts of the enamel really well. And so I don't want any moisture in that. So alcohol is just something that I do, and then blow it dry, conditioner, blow it dry, place the bond, and really try to scrub it, and then light cure it. And then I am using a buildup cement, comprimer, and just kind of doing some layers. I'll cure up to the chamber, if you will. So that first step was just a little bit countersunk inside the root, and then did a quick cure. This is a dual cure cement comprimer, and now I'm going to fill up the cavity. And you can do incremental layers, and it's definitely advised to do that. And again, when I can get in on a lot of surfaces, I'll do that. Just like I kind of said with the sound seal, you kind of let it get kind of semi-set. You just let the ambient light kind of work it. Don't go right into adjusting and smearing it on that class 2 wall until it gets a little bit semi. It's kind of hard to explain, but it just starts to thicken up. It's actually easier to do that little manipulate. Now, I can't manipulate very much, but I'm just dragging it. I want to make sure those margins are closed. That's why. Do a couple more cures. 34 minutes into it. Again, I'm really trying to be done in 40 minutes or an hour, depending on how the check-in time was, or if they were a consult or a consult treat same day. But if they're consult treat same day, it's 40 minutes, because it takes 20 minutes to do the paperwork and check in and check out stuff. So I like being in the treatment spot around the 40-minute mark. Just going to do a little bit of shaping here. Just kind of lowering that distal wall down to the, so it's just flush with the adjacent tooth. That's all I'm doing right here. There we go. So we're gonna have to check that occlusion here. Tap, tap, tap. Grind. I always like to massage the muscles. They've been open for a while and get them to wiggle that around and really focus on excursive movements. And I know you guys are all masters and mavens out there, but you can see that I've closed those margins. And I'm gonna pause this here because I wanna talk about this a bit. Now, what's interesting about it, so again, I've closed these margins and that's really useful. I mean, really useful. And then you can see where I've looked and I've taken that Munspur down to about this level, and there was sort of a stone somewhere in here, and then I get into the fork. And I believe the GentleWave really opened this part up right here, and then it gets into the fork and the bend, and this is where it was really steep right here. And we can see that they reconnect here. And if you remember, I flushed the GentleWave through this system, which allowed my passage for the file, and I did that just for convenience and shape. But what I find very fascinating is this little streamer that comes up right here. So yes, we can see the macro anatomy, the macro canal that goes here and then forks here. But I have a little connection, a little tertiary division that's coming out here that we can see on it. And so it's a really interesting technique, and you know, it's a little bit out of place because I ran the GentleWave up front, and again, I kind of felt forced into it, and I think it was a safety thing for the patient. I mean, it made me safer. I was getting worried about those files. That was quite a tight fit, and I was happy to reach my working time goal of under 40 minutes. And I feel like this was a great service. Now, that's what I've seen with the GentleWave. I find that there's these circumstances that it really speeds me up in. Otherwise, it's sort of the same protocol. But I find myself being able to do jobs a little bit different, a little bit more efficient, a little more effective. And I feel better that I'm actually disinfecting and debriding and removing the vital pulp tissue down there in the apical third, unlike I've never done in my career, because there's no way I could see this kind of stuff. The macro anatomy, the primary canal anatomy kind of blocks me out of that apical third. And so I've gotten a lot more trust with the fluid than, you know, I guess when I got exposed to the technology, I was hoping that this would be the case. But it was really comforting to find out that it actually is that way during the case. In summary, we had a nice technique to show you the platform build. Took me a while to kind of master that, to get my workflow down and be really fast and efficient and try to get that perfect pass the first time. So hopefully those techniques actually help you learn from my trials and errors. And you know what? If you like what you see or want to participate, Dental Learning Live is an open source platform. So if you want to use Dental Learning Live and do one of these on your own, just let me know. But hopefully this was a great demonstration, if you will, of the GentleWave technology, what it does for our patients and how it keeps us on time in difficult anatomy. So appreciate you guys joining. Feel free to comment. We always like to see the comments down below. If there's a case type or something that you want, subscribe so you can get the notifications as these things come out. There was a technical difficulty on YouTube. They did some sort of update and changed their format. It was brand new, and apparently you couldn't do a live stream today. So great day to do a video, not a great day to stream a live stream apparently. So thank you all, and till the next time.